So the first speaker is Dr. Atheer Razzouk, who's a R1 resident.
Today we'll be talking about whether gastric residual volume will correlate with aspiration pneumonia in patients who are receiving gastric tube feeds in the ICU. In patients receiving internal tube feeds, gastric residual volume, which I'll refer to as GRV, refers to the volume of fluid remaining at the stomach in a given point in time. And I tried to find the origin of why or when this practice started, and I couldn't really trace it back to a certain year or decade. But I did find this quote in an article that I was able to read and find. So it says, the practice of aspirating GRV mysteriously appeared in nursing texts several decades ago, years after enteral nutrition was introduced. And it's difficult to basically trace the origin of when it actually started. So in theory, increased GRV will lead, plus decreased gastric motility in ICU patients, usually leads to gastric overdistension and regurgitation, which is thought to lead to aspiration and subsequently aspiration pneumonia. But what's the evidence for that? Gastric residual volume, the idea is in early critical illness, nutrition is very critical. It maintains mucosal integrity, it helps with immunity and infection rates. But also in very sick patients, gastric emptying is often slowed, and that can lead to elevated GRVs and subsequently aspiration. So since aspiration and pneumonia is a very feared complication, GRV monitoring is often used as the marker for feeding intolerance in these patients. And again, with the thought that it could lead to aspiration pneumonia. So for this reason, a lot of places often discontinue tube feeds after a certain GRV has been monitored, usually, like Dr. Fried said, around 250 or so. And there's long-standing controversy about this, about the presence of high GRVs or whether or not it is appropriate or acceptable to measure them. And is it worth sacrificing nutrition for the sake of preventing or presumed sake of preventing aspiration and pneumonia? So the myth, again, is, do GRVs correlate with aspiration pneumonia risk? And for that, I looked at some studies, so let's find out. The first one is called, it was from 2005, called Poor Validity of Residual Volumes as a Marker of Risk of Aspiration in Critically Ill Patients. It was a prospective study. It looked at 40 patients who were randomized to two groups, one where they stopped feeds at any GRV over 200 and the other over 400. And they did bedside evaluations every 4 hours and to check the GRV position and collect secretions from both the trachea and the oropharynx. They kept and monitored several scores. And the aim of the study was to determine whether GRV accurately predicts aspiration risk, whether there's a cutoff that we can use, and whether clinical findings can correlate with aspiration. So the results of the study, on the right, we see some of the scores that they kept. So the top is the aspiration risk score, and the bottom is the bowel function score. They had actually found that of the 40 patients in both groups, 85% had at least one episode of regurgitation, and about 75 had at least one episode of aspiration, or 75%. The mean GRV, which is interesting for regurgitation, is only 35.1 mLs, and for aspiration was 30.6. And the incidence of aspiration, they found, did not really correlate with regurgitation as well as the scores that they were keeping track of. So with this table, basically looked at the incidence of regurgitation and aspiration by a range of residual volume. So they have different ranges here, and basically the frequency of aspiration didn't really change over wide ranges of GRV, although most of the GRVs were in the 0 to 50 ml range. If we look at the percentage, it's pretty much the same or close. And so this study basically suggested that there's virtually no relationship between residual volume and risk of aspiration and regurgitation. This table here shows the sensitivity and specificity and other factors at different cutoffs of GRV. And two things to look at here is there's extremely low sensitivity of GRV to detect aspiration, and it doesn't significantly improve as you increase or decrease the cutoff value. And then two, there's very poor positive predictive value, indicating that when GRVs are raised above the cutoff, they were only present in between 18 to 25%. The next study that I looked at was from 2008. It's called the Gastric Residual Volume and Aspiration in Critically Ill Patients Receiving Gastric Feedings. This one was, it tried to describe the association between GRV and aspiration of contents in groups of critically ill patients that were receiving tube feeds, all of whom were intubated. And they selected 206 from different services, and who were receiving gastric feedings for 3 consecutive days, and they were measured every 4 hours. And they had 3 different groups that were overlapping. So groups that had at least 150 GRV, groups that had at least 200 and at least 250. Measurements, not groups. And they categorized the patients as either frequent aspirators or infrequent aspirators, and they used a cutoff of 40% of their tracheal secretions, which were positive for pepsin, and that's how they determined whether they aspirated or not. And they did a pepsin immunoassay to detect that. So here in this graph, it basically shows the percent of pepsin-positive tracheal secretions at different gastric residual volumes. And remember, they used the cutoff of 40%, and basically we see at even GRVs of 51 to 100, they were already above 40%, indicating that it's not really at any, so any range can actually give you aspiration. The results, they determined that there was no consistent relationship between aspiration and GRVs. However, aspiration risk was increased as you went up, but there were some limitations to the study, and their conclusion is that they suggest that it's prudent to measure GRVs every 4 hours in critically ill patients in an effort to determine which ones aspirate and which ones don't. However, things to consider was the marker that they used is very sensitive, pepsin assay, and basically even healthy patients and you and I aspirate. And their end point was not aspiration pneumonia, it was just aspiration. So that was another limitation. And the third thing was that about 50% of the patients of whom they measured GRVs, they used small tube feeds, and those are notoriously known to not be accurate or to not have any accurate measurements. Study number 3, so this one is the gastric residual volume during internal nutrition in ICU patients. This was, I believe, from 2010. And what this study did is it was a prospective randomized study. They looked at 322 patients, and they compared the effects of increasing the limit in the adequacy of internal nutrition. So patients were assigned in a control group where they kept the GRV at 200, and then a study group where they kept it at 500. And they measured several things, including ICU-acquired pneumonia. So findings in regard to aspiration was that basically the use of GRV was not been shown to decrease the incidence of aspiration or VAP, or ventilator-associated pneumonia, which supports the finding of this was the slides were rearranged, but of the first study that I had went over. So 2 tables here to look at. So on the top left, basically the important thing to notice is that 0 patients aspirated in the control group versus only 1 in the study group. And then on the bottom right here, about 27.3% of patients had ICU-acquired pneumonia in the control group, keeping it at 200 versus the 28% of the 500 mLs GRV group. So it's pretty close. This study looked at the effect of not monitoring GRV on risk of ventilator-associated pneumonia. This was, I believe, from 2013. And what this study did, it was a randomized study, non-inferiority, open label, with an intention to treat analysis. It looked at 452 patients, 3 of which withdrew, who required mechanical ventilation for more than 2 days, who were started on enteral feeds within 36 hours after intubation. And the objective was to test the hypothesis that if we don't monitor GRVs, will the risk of ventilator-associated pneumonia go up? And so the intervention group was not monitoring the GRV. The control group was to monitor. And they used 50 ml syringes through an NG tube to draw the residual volume. So their primary outcome was the proportion of patients with at least one VAP episode in the intervention versus the control group. And they measured other secondary outcomes, including cumulative incidence, total number of VAP episodes, the microorganisms, and other factors. So what we see here on this graph, the black line is the control group and the blue line is the intervention group. And this is the cumulative incidence of pneumonia, ventilator-associated pneumonia, and the time to detection. And we can see that it looks pretty much the same. So the result was 38 of the 227 in the intervention group who did not have GRV monitoring, or 16.7% versus 15.8 in the control group had ventilator-associated pneumonia. So it was a very narrow difference. And this graph right here looks at, so vomiting occurred higher in the intervention group versus the control group. However, the intolerance to enteral nutrition was higher in the control group because they measured intolerance to feeding in the control group as a GRV of 250 and vomiting versus they only measured vomiting in the group that wasn't monitored. Other things to look at from this graph is at the bottom here, there was really no change in mortality. It was about the same at 28 and 90 days. And hospital length of stay, ICU length of stay was pretty much similar in both groups. This graph here shows the percentage or the proportion that achieved their caloric target in the intervention versus the control group. And in the first few days, the intervention group achieved a higher percentage of calorie target in their nutrition. So the conclusion from this study is that not monitoring GRV is not really inferior in terms of protection against VAP, which is the feared outcome, or new infections, or hospital length of stay, or mortality. And GRV really failed to correlate with regurgitation or aspiration rates. So they concluded that it led to unnecessary interruptions in enteral nutrition feeds in critically ill patients, and they basically said that it should be eliminated from the standard of care. So VAP is more really attributable to secretions, subglottic secretions rather than gastric secretions. Some studies like this one looked at, it showed a strong, it suggested that aspiration pneumonia was more attributable to oropharyngeal colonization than gastric colonization, and they used bacterial DNA analysis to kind of determine the microorganisms. So, I mean, are we really doing these patients a favor? Are we measuring or monitoring their GRV in terms of, preventing aspiration pneumonia? Again, it's based on the presumption that it's an accurate marker of gastric contents, and that if it's increased, it'll suggest impaired emptying and to stop tube feedings before we have a pneumonia that's happening. And if we really set an arbitrary threshold for a GRV and stop tube feeds, it'll prevent patients from getting their nutrition. And as we saw earlier, nutrition is very important early on in their critical illness. So, I mean, should we keep monitoring GRVs as a marker for aspiration risk? There was a guideline from the Society of Critical Care Medicine and ASPEN, the American Society for Parenteral and Enteral Nutrition, that asked the same question. And what they came up with was, based on studies like the ones I mentioned, is that they suggested GRVs not be used as part of routine care to monitor ICU patients. Furthermore, they suggested that if they are still being monitored, any GRV less than 500 mLs, if there are really no signs of intolerance, we should just not stop feeding just because of that. And the idea of measuring a GRV itself is not really standardized or validated. There's no one technique that says this is how we're supposed to measure GRVs. It's affected by many different things, like the tube position, the tube size, the patient's position, how many tube openings, the sizes of the syringe, and who's doing the measuring itself. And so another thing to consider is that our own secretions, saliva and gastric secretions, are about 4.5 liters a day. And if we average that per hour, that comes out to about 188 mLs. And if we assume normal gastric emptying, of 35 to 50% per hour, and tube feeds between those two rates, 25 and 125, theoretically, our residual volumes plateau between 230 and 460 within 3 to 6 hours after starting tube feeds. So having that cutoff of, let's say, 200 to 500 doesn't take into account these secretions, and it can actually, again, prevent the patient from getting their optimal nutrition. While it is important to assess enteral nutrition intolerance in ICU patients, if we just stop their feeds based on a GRV, that's been shown to not be recommended. And it is reported that about less than half of ICU patients ever reach that calorie goal. However, they still need to be monitored for daily enteral nutrition intolerance. So how do we do that? Daily physical exams, bowel movements and passage of flatus, if the patient's communicable, asking them about symptoms of bloating and other things, reviewing images that they've had, and again, the patient's own complaints. So in summary, there's really, what I found is no true correlation between GRVs and risk of aspiration. Enteral feeding cessation based on just a set value of GRV is not recommended and can result in underfeeding. And instead of GRV monitoring, it's better to assess the patient for risk of aspiration using the things I mentioned: physical exam, communicating with them, and passage of gas, abdominal pain, distension, things like that. Just common findings. And so patients who aren't tolerating intragastric feeds, there's been some discussion about post-pyloric feeding and prokinetic use may result in enteric food intolerance. However, they don't really decrease mortality. So these are the references that I used.
Anybody have any comments or questions? So the question was there any reason to monitor gastric residual volumes in the other than aspiration pneumonia risk? As far as I know, there is none. Correlation between GRV and length of stay in the ICU. I think that one study, they didn't see any relationship between GRV volumes and ICU lengths of stay. None on survival either, right?
Yeah.
Okay.
And the strongest correlation with checking them has been that patients just don't get the feeds.
Yeah, the strong, as the dietitian said, Dina said that the strongest correlation is that the patients don't get the adequate nutrition, which was brought up here. Yeah, Dan?
Do you think maybe all these categories are way too low? There's 50 to 100, 150 to 200, so all these low volumes are okay, but maybe over a liter don't feel good. So do you think that they ought to have had higher volume parts in the study?
So the question is, did they go high enough? These studies went as high as 500 milliliters, I think, that were presented. If you go as high as a liter, maybe there'd be a correlation, but by that time, I think you'd be seeing abdominal distension clinically, and you'd already know there's a problem. I think that was the point they were trying to make.
Right. So anything that was less than 500, if there were no signs of abdominal distension or anything like that, was to not stop feeds or measure them, or not stop tube feeds.
The question is, what are the routine prokinetic drugs?
Erythromycin was one, and metoclopramide was the other that I saw in the studies that I read.
The comment, if you couldn't hear it, was we don't really scale the volume to the patient's size, and obviously a much larger person is going to have a greater tolerable volume, larger stomach, which adds even more variability to the recommendation of a set cutoff for everybody. Okay, I think that's all the questions. All right, so as you may remember, so now we get to vote. So how many people think that we should be continue to measure gastric volumes and that they do correlate with aspiration pneumonia? How many think that it's plausible? Maybe we should keep doing it? And how many think this is a myth and it's busted? All right. Busted.